Dear Chairman, thank you very much for inviting me for this meeting, the Bifurcation Club 2021, and hope to meet you physically next year, inshallah, after the COVID-19. Each of us would like to simplify the procedure, but sometimes the winds come with unexpected scenarios, and this is what happened in this case. So what looks easy is not usually easy. My patient is 60 years old, female patient, hypertensive, smoker, complaining of typical exertional chest pain, the maximum medical treatment with normal echocardiography and the normal resting ECG and positive stress test. I decided to do coronary angiography for her, and I found mid LED calcified lesion with 80 to 90% stenosis. This is the coronary angiography of the patient here. Very tight stenosis at the level of the diagonal, sizable diagonal branch. This is the tight stenosis. I decided to prepare the lesion by using a balloon 2.5 by 15 balloon at 12 atmosphere, inflated the balloon at 12 atmosphere. And this was the surprise after inflation of the dilatation. Perforation at the carina with the diagonal branch. So how do you stop bleeding from the coronary artery? I started by the regular method using ballooning for the perforation for 10 minutes. After ballooning for perforation, still the perforation is present. Balloon inflation was continued for 10 minutes. ST segment elevation with BVCs and OCG. Patients suffer from chest pain. The blood pressure gradually decreased. This was a very stressful condition. How do you stop bleeding from the coronary artery? So I decided to go to the next step to search for the output graft stent. But this was the second surprise. I didn't found the sizable graft stent at this moment. So do you know, over the wire balloon, I was lucky and the patient was lucky. The over the wire balloon, as we see here, has two lumens, lumen for the wiring and lumen for inflation. So I pulled back the wire. I injected self-blood in this lumen, and the other lumen, I inflated the balloon and to block the part of the perforation and maintaining the distal diffusion for the myocardium. I put a long wire, 300 centimeters, then I put over the wire the balloon, and then I inflated and pull back the wire, and I injected self-blood into the wire lumen of the over the wire balloon by putting another sheath in the contralateral side of the femoral artery and taking self-blood and then re-inject this blood into the lumen of the wiring in the over the wire balloon. This is the principle of this balloon, of this my technique. I pull back the wire, inflating the balloon, injection of self-blood into this lumen. So I'm maintaining the distal diffusion of the rest of the myocardium. After this method, injection of self-blood, the ST segment elevation was decreased, and the chest pain of the patient disappeared. I maintained the inflation for 20-25 minutes continuously with continuous injection of self-blood. Here, as we see here, over the wire balloon at the site of perforation and distal perfusion is maintained. Here, I blocked and I inflated the balloon at the nominal pressure. I think it was 8 or 9. Then I put the guide wires, deflating the balloon, and reevaluate. And this is the final angiography after the over-the-wire balloon. The perforation is sealed. Good BTCA. This is another projection. Here also, good BTCA. I decided after this good angiographic result to stop at this level and put the patient on dual antiplatelets and on the maximum medical treatment and stop at this level. My take-home message is PCI is not just passing wire, inflating balloon, or putting stents. It's a matter of how to deal with complications. Over the wire balloon could be a simple method and effective method to seal perforation of type 2 and 3. Thank you very much for your attention.